All right, good morning, everyone. Welcome to the PT on Ice Daily Show. My name is Jessica Davis, and I'm coming to you live from Pittsburgh, Pennsylvania on a cold, rainy fall day. Not my favorite kind of weather, but I'll take it. And I'm here today to talk about snapping hips. So I'm lead faculty, for those of you who have not met me. I'm lead faculty for the Performing Arts Division, and as I said, I'm located in Pittsburgh, Pennsylvania. And I apologize, I'm up here early this morning. Will be teaching in a little bit, so had to go on live early. So wow, there's a lot of early birds this morning. Good morning, everyone. Okay, we're going to talk about snapping hip. So I do see this a lot in my dancer population, but I want to talk about how you're going to see this across the orthopedic spectrum. You'll see it in athletes, any athlete that's going to be taking that hip through a large excursion of range of motion. And it's important to be able to understand what's going on, the mechanisms, and great ways to identify special tests. So we're going to talk about that today a little bit. There was a nice article that was published in 2017 in the Journal of Rheumatology that I'm going to reference for you because that's where I got a lot of this information. It's just a nice summary of specific tests and measures that you can do, and I was quite impressed with it. So the big thing that you're going to hear these patients report to you is that they feel a snap. They will tell you, my hip snaps or my hip pops. And the interesting fact is that across the spectrum, there's about a 10% a prevalence of this. However, they do feel, the authors reported that, it's probably underreported because a lot of, especially in the dance world, a lot of these patients will have a popping in their hip and they feel that's normal. So they're not going to report it. So it becomes an issue, as with anything, when it becomes painful and limiting in their functional abilities. So the key here is they're going to report a snap. And the other aspect is that it will be painful and limiting. So there's two aspects of this. So there can be an internal snapping hip or an external snapping hip. So I'm going to go over just different ways that you can identify and help identify what's going on and where to locate it. So with the external snapping hip, what's happening is that there is either a thickening of the proximal aspect of the IT band or of the glute max. So I'm going to show you, I have my skeleton with me today. So what happens is, I'm sort of clumsy. That's funny. Anyway, okay, so you'll get an aspect of this glute max that will be a little bit more prominent and built up thickening, or it could be the IT band. And what happens is it will lie, when the patient's in extension, it will lie on the posterior aspect. And what happens when they flex their hips, so with gait, as they put their weight on and they're transferring and they're bringing into flexion, they're going to report a painful snap. So as this hip comes into flexion, what happens is this band of tissue will then snap over the greater trochanter. So these patients are going to point to you and they're going to tell you that right here is where I get my snap. So a key variable, again, with a differential diagnosis with this patient population, they said one of the most sensitive tests is actually the ability to reproduce the snap. So the patient will have a mechanism and they'll specifically tell you, when I do this, I get this snap. And you just say, show me, because you want to see where it is. So if the patient points laterally or slightly posteriorly, be suspicious that it's more of the external snapping hip mechanism involving the IT band glute max. We're going to get into that later. Internal snapping hip is the psoas. So could be a variety of anatomical variants actually with this patient population. So it is when the psoas will then snap over the femur. And so these patients are going to point to you more in the anterior type groin area, and they're going to reproduce the snap in a different mechanism. So as I said, the key variable is they're going to be able to reproduce that snap. And then you want to, with these patients, evaluate their gaits. You're going to get a good sense of how they're ambulating, and a lot of them are going to want to avoid, they may do slight things. So they may stand, you'll see these patients often stand, and they'll kind of maintain this hip maybe slightly in an internal adducted type positioning. So they may hold that position. They're going to try different mechanisms where they don't get that snap either internally or externally. So assess how they're standing, assess how they're ambulating, and then you want to be clear to rule out an internal articular pathology, right? So these patients, especially the internal snapping hip, you can see it simultaneously with FAI. So our special tests are important here. Now, the Fade-Air test, which is flexion, adduction, and internal rotation, so you can see with my skeleton, so you guys know the Fade-Air. So this test, they said, is a good test to clear intra-articular pathology. However, Faber in this patient population can be positive for both snapping hip as well as an intra-articular pathology. So take that with a grain of salt. And we know there's special tests. We need a combination of special tests when we're looking at intra-articular pathology for the hip. But remember that you may actually be able to reproduce the snap with the Faber test. So again, the Ober test, in the Ober test position, when you put the patient in the Ober test position, you actually also may reproduce the snap for this patient population. So pay attention to that. We're looking for, is there a soft tissue restriction variable? So are they tight in their psoas, hip flexors? Are they tight in the IT band? And then the question becomes, is the tightness compensatory? So are they tight there because they're protectively guarding, or they're hyperactive in that area and they're underactive in the glute region? So it's important to differentiate the two. So that's where you have to get good with your clinical assessment, right? So a special test for the external snapping hip is just the modified Faber. So you take the patient and you have them kind of sit cross-legged. Maybe I'll lower this so you guys can see. So you have the patient just sit in a cross-legged position, and you just have them push this knee out here. So that will reproduce their pain. It may or may not reproduce their snap, but that's a modified Faber. And again, as I said, the regular Faber test may reproduce the snap as well. For the internal snapping hip, a special test that you can do to differentiate this one is you would lay the patient supine. That's why I brought my skeleton today. So you're going to lay the patient supine. So imagine that my patient's supine here. So I'm going to take the patient into hip flexion, external rotation, and a slight amount of abduction. Then what I'm going to do is take this hip and bring it into internal rotation, adduction, and extension. So a positive test, so I'm bringing this hip into this positioning. So again, external rotation, abduction, flexion, bringing it into internal rotation, adduction, and extension. And a positive test for this is a reproduction of the snap at 30 to 45 degrees of hip flexion. So if you get that, be highly suspicious. Palpation's valuable here. So you're going to find tenderness, you're going to find restrictions. But again, it's interesting with this. So we can't really utilize radiology for this. The primary diagnosis is clinically, but the key variable to remember is the patient should be able to reproduce the snap. So that's the most sensitive of all the tests. If they can reproduce it, it is what it is. But then as a clinician, you need to figure out, okay, so why is this happening to my patient? And most often these patients can be rehabbed conservatively, and that's what we want. There is some literature out there about injections, and what they found, as we see with most injections, is that they'll get a short-term pain relief if they have, a high inflammatory response, but the outcomes after a year are the same, whether it was managed conservatively or they utilized an injection. So you want to avoid that if at all costs. So you want to manage these conservatively. The key, however, is you can't just assume that it's a soft tissue restriction. You can't just work on flexibility and miss the boat if it's more of a motor control issue. So that's when it gets intricate, and you need to really know your patient. You need to know what they're putting their bodies through. So when you're looking at them, you need to you do your special tests, see if there's some soft tissue restriction, but then observe movement, observe functioning, and look to see, are they actively engaging their glutes, or are they hyper-recruiting the TFL perhaps, or are they hyper-recruiting the psoas? Are they truly, is it weakness, or is it a lack of motor control? So again, I'm going to reference, when it comes to the hip, I'm going to reference Sarah Haran, because I just think she's brilliant when it comes to the TFL down training and all the exercises that she has. So go back and watch her videos if you haven't seen them. I highly encourage you to take the time to review these, because this is a patient population that's going to benefit. So remember, they can coincide with underlying FAI issues, but they can be of themselves. And I will say this can be quite debilitating. So I've seen in my dancer population, this can be a huge limiting variable because it affects their ability to come to that end range of motion. And with any athlete, if they can't get to that full range and they can't participate, this snap becomes quite painful and debilitating. So, and it can be scary too. So I've had a few patients just report to me, it feels like my hip's coming out of place. It's important to educate. The other thing I wanted to go over though that you need to look into is making sure that you clear hip instability. So a common thing is anterior hip instability in this patient population. So you need to do a special test of the apprehension test. So it's similar to the apprehension test of the shoulder. So you're taking this hip, imagine you have your patient sideline. So you're taking this hip into external rotation, and I'm going to put their foot on the table. So I have that anchored behind their other leg. And then what I'm going to do is stabilize posteriorly, and I'm going to take my hand at the femur, and I'm just going to push this anteriorly. So when I do this, if it reproduces a lot of their anterior pain and you feel a lot of movement or excursion, and it's different side to side as we look for our special tests, be aware that this patient may have some underlying ligamentous laxity / instability contributing to their over-recruitment of their muscles. So again, this is a patient that we're going to be doing a lot of motor control. So you're going to be doing a lot of patient education, a lot of hyper focus on specific exercises. In this patient population, I do a lot of sideline PNF, trying to get the glute to activate, trying to get that TFL to turn off, trying to observe and allow for that range of motion that they need into flexion without getting the reproduction of the snap. You are going to use, whether you want to do instrument assisted or soft tissue work, whatever, to release the tissues around. They benefit greatly from that. But remember, with this population, it's often motor control, as we see with most things. So again, you've got to get that patient to those end range of motions without reproducing the snap. So it becomes a lot of patient education, a lot of home exercise programs, and addressing the primary motor control impairments. If it's pure soft tissue, it's a lot of active and dynamic stretching. So you have to differentiate that in your exam. So anyway, I hope that was helpful, and thanks for listening. Everybody have a wonderful week. And yeah, enjoy your day. Thank you for watching. All right, take care, everyone. Thanks for watching early in the morning. Bye.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.